Hi, I'm Dr. Donovan with TheDispensaryOnline.com. I'm here to talk about inflammatory bowel disease. It's one of the specialties that I've dealt with now in my office for many, many years. I used to teach gastroenterology at Bastyr University's medical school, the School for Naturopathic Medicine, and somehow began to accumulate a number of patients here at my office who had Crohn's and colitis. And over the past 15 to 20 years have developed a special interest in treating Crohn's and colitis. Now, IBD, inflammatory bowel disease, pretty understandable. Inflammatory, so it's an inflammatory disease. It's an autoimmune inflammatory disease, meaning that the inflammatory component is you attacking you. So your own immunological system is attacking your own tissue within your gut, within your intestinal tract, causing an inflammatory reaction. And that inflammatory reaction can be quite pronounced. And it can cause bleeding, it can cause malabsorption, destruction of aspects of the intestinal tract. Now, under IBD are three primary disorders, if you will. Ulcerative colitis, idiopathic ulcerative colitis, Crohn's disease, and microscopic colitis. These are the three subdivisions, if you will, or subtypes of inflammatory bowel disease, which is the umbrella term. Let's talk about ulcerative colitis first. Ulcerative colitis is an inflammatory disease, as I talked about, that occurs primarily in the colon. The more common place for it within the colon is in the left or descending colon, and in the sigmoid pouch. That's called proctitis. The inflammation can cause ulceration, causes a reddening. When you look at the pictures or you look through a colonoscopy through the scope and you look at this, you can see this blushing of the mucosa, redness of the mucosa, and in many cases an ulceration of the mucosa. That ulceration causes a lot of bleeding. Ulcerative colitis is known for its diarrhea and its blood and bloody stools. And so a patient who begins to exhibit symptoms of ulcerative colitis will first show symptoms of pain, usually crampy pain just before stools. There'll be urgency to the stool, and the stools can sometimes be multiple but small, and those stools can have a gelatinous-like bloody constituency to them. That's classic presentation for ulcerative colitis. And Crohn's disease happens anywhere from the mouth, or if you will, the lips, to the rectum. And Crohn's disease is also an inflammatory disease. The inflammation of Crohn's disease goes more all the way through. It's called transmural. More all the way through the intestinal mucosa into the wall of the intestinal tract, and can sometimes cause perforations and leakage into the abdominal cavity that allow for the development of abscesses and what's called fistulas. These are like little tunnels, if you will, of infection. Crohn's disease is a lot more serious than ulcerative colitis in that it can be more distressing all the way around, because you can have a strong malabsorptive component to it, because it involves the small intestine more primarily than any other part of the GI tract. And the small intestine is very, very important for the absorption of our proteins, micro and macronutrients, minerals, etc. It used to be called a regional enteritis or distal enteritis. Enteritis meaning inflammation of the small intestine. And the area where it most prominently occurs is the distal end of the small intestine. And why is that important? Because that's the area we absorb B12 from. And when there's localized inflammation there, our ability to absorb B12 drops dramatically. So this disease process already begins to cause nutrient deficiencies, B12 being a big part of it. Now, both ulcerative colitis and Crohn's disease because of their inflammation, because of the diarrheas, and also because of some of the malabsorptive pieces, can have serious anemias associated with them. And in the situation of Crohn's disease, it can be B12 anemias as well as iron deficiency anemias. In ulcerative colitis, it's primarily iron deficiency anemias because of so much blood loss. Then the third classification, microscopic colitis. That's a colitis that usually is more prominent after the age of 50, so we see more older adults beginning to display the symptoms of microscopic colitis and being diagnosed with microscopic colitis. Now, let's look at it. Microscopic colitis. So it's not the kind of colitis that when you look up with a scope, up the rectum with a scope and have a colonoscopy done, it's not the type of colitis that you can see. You can't see the erythema, the redness, you can't see ulcerations, etc. It's microscopic. So this is a job of the pathologist in diagnosing this. And so any specimens that are taken are then looked at by the pathologist as all these specimens taken during any colonoscopy, if it's for anything from risks of cancer to ulcerative colitis to Crohn's disease, they're all, specimens are always taken and a pathologist always takes a look at them. But for microscopic colitis, the pathologist can only diagnose it on a microscopic slide. They're looking for specific changes. There are two primary types of microscopic colitis, collagenous and lymphocytic colitis. Both are associated with celiac disease to some degree. Lymphocytic colitis a little bit more, but both can be associated with celiac disease. And I most commonly see the diagnosis of microscopic colitis in adult patients who have been latently celiac or have had latent celiac for years. And it's the gluten pathology that begins to set up the microscopic colitis. So all patients with IBD should be screened for celiac disease. Patients with microscopic colitis certainly should be screened for celiac disease. As I said, every single adult patient that I've either diagnosed or has been diagnosed by one of the gastroenterologists I work with, all of them have shown positive studies for celiac disease. And so all of those patients are off gluten. That's sort of the overview of IBD. Now, there are ways to treat IBD, certainly through medications. There are numerous medications out there that are effective and from various levels. At the top, we have medicines like Remicade, which is a very strong immunosuppressant medication and is given IV every 4 to 8 weeks, commonly every 6 weeks with patients. Serious risks in using it, although when a patient needs it, it is one of the best medicines to utilize. Now, there are also other medications such as 5-mercaptopurine or azathioprine, also an immune suppressant. And then there are aspirin-like compounds called salicylates, Asacol, Dipentum, Lialda. These are also used to treat colitis and Crohn's disease. Now, prednisone has been the classic standby for 40, 50 years as the primary acute treatment for IBD. And many of the doctors are not happy with having to use it long term, and I don't recommend it either. Some of these other medications, specifically the salicylates, if a patient responds, are quite good. Now, I just want to quickly overview those as I have. I'm not going to spend any time with those medications because I'm here today to talk to you about dietary ways of treating Crohn's disease, ulcerative colitis, microscopic colitis, and some natural remedies that can be very effective. Now, I'm not recommending at all that we do one or the other. In my office, we treat a patient with adjunctively with all and any of the medications, dietary changes, and nutrients that they need to maintain the most optimum wellness with regards to their disease. So in each case is individual. Now, from a dietary standpoint, The diet that I find to be most effective for IBD, specifically Crohn's disease, but certainly for IBD in general, is the specific carbohydrate diet. Now you can go, excuse me, you can go online, you can look at Lynn Gottschall's book, Breaking the Vicious Cycle, that introduced this idea, this concept of dietary treatment for IBD. And you can look at her work, you can order the book, you can also go online. There are a lot of blog sites for the specific carbohydrate diet, and you can learn a lot about the diet and begin to utilize that diet in your own treatment program. I believe there are some pilot studies being done by the University of California Department of Pediatric Gastroenterology on the specific carbohydrate diet. I haven't heard of how far along they are in those studies, but I have talked to some doctors who are planning to set up some clinical studies for the diet. Now the diet, I'm just going to give you sort of an overview. The diet really takes out all grasses and grains from the diet. Most grains are grasses. So it takes out all the grains from the diet and other sources of particular types of carbohydrates and high carbohydrate foods, such as potatoes and certain beans, etc. Now, I think one of the ways in which this diet works so well is because many of the patients who have utilized it successfully may also be celiac patients or latent celiac patients. That's the second tip for dietary treatment of IBD, is I really believe that patients with IBD have to be sufficiently tested and screened for celiac disease. Now, in my book, that means doing the genetic testing, looking for the HLA DQ2 and DQ8 genetic haplotypes that put a patient at risk for celiac disease. Looking for the serological markers, those are anti-gliadin antibodies, IgA, IgG, looking for the transglutaminase and anti-endomysial antibodies. And then also being biopsied. And when the biopsy is done, making sure that the pathologist is looking at all three levels of Marsh criteria in the pathological specimen so that they don't miss some of the early changes for celiac disease. Now, it is recommended every IBD patient be screened for celiac disease. About 40% roughly of patients with Crohn's disease will be found to have an associated celiac component. So it's very important. As I mentioned earlier, that microscopic colitis, those patients have much more preponderance of celiac disease associated with their disorder. So microscopic colitis, roughly about 65 to 80% of patients I'm finding will have some markers positive for celiac disease. That is probably the best two dietary pieces one can be evaluated for and begin employing within their treatment plan. Next is to be tested for any food allergies. Probably the best test is an IgE RAST, R-A-S-T, RAST test. Most labs offer that. I like to see at least some 50 to 100 foods looked at in one panel to see if there are any immunologic or allergic reactions to some of the proteins you're taking in. Not that they cause IBD, but certainly if you're having localized inflammatory allergic reactions in the mucosa of your GI tract, that's just going to worsen the situation. So you want to identify those foods you can be allergic to and get rid of them. Also, identifying any lactose intolerance. That can be easily done through some blood tests. You're challenged with a certain amount of lactose, and then your blood is tested before that and then every half hour after that to see if you have lactose intolerance, and that would take dairy products out. Next is some specific botanicals and supplements that can be very, very helpful. Probably at the top of the list is curcumin and curcuminoid compounds. The curcumin compounds are from turmeric, the spice turmeric. The curcuminoid compounds are some of the most researched natural compounds now in the world. They are so impressive in their anti-inflammatory capabilities and anti-cancer capabilities. Now, patients with IBD, most specifically colitis, but also with Crohn's disease, have an increased risk of developing colon cancer, and it's nearly doubled every 10 years of active disease. And curcuminoids not only reduce inflammation locally in the intestinal tract and the mucosa, but they commonly do it from in a direction that medications like Remicade do it. So they almost are exactly like Remicade in the ways in which they interfere with certain cytokine and inflammatory cascades in the intestinal mucosa. And then there is another plant compound called Boswellia. It's commonly known as frankincense. And Boswellia has been studied as well as an anti-inflammatory and has strong anti-inflammatory capabilities, very similar to the salicylate drugs that are used for IBD. Now, I use both of these compounds together, and I use products that have them blended together. And I use some pretty high doses, and I use only the standardized concentrated extracts of both. So I know how much I'm getting, and I know that I'm going to get a clinical value or a clinical efficacy value of using those compounds. So those are probably two of the most valuable compounds that can be used from a botanical standpoint. From a nutrient standpoint, we have to pay attention to folic acid. Some of the sulfasalazine and salicylate-related compounds or medications like Lialda and mesalamine and some of these others that are commonly used can inhibit the uptake of folic acid. So having extra folic acid on board is very, very important. Zinc is another nutrient that's important, specifically in Crohn's disease, or in patients with Crohn's disease. They will often develop these fistulas that I talked about and fissures. And there's good peer-reviewed literature showing that zinc enhances the healing and reduces the occurrence of these fistulas. Vitamin C is also very important in the healing of fistulas. Now, many patients with IBD will also develop extra-intestinal manifestations of the disease because the intestinal tract gets so leaky to the bacteria and bacterial proteins and food proteins. Some of these proteins, not the bacteria themselves, but some of the proteins associated with the cell walls of the bacteria can leak across the gut. And when that happens, those compounds, those larger proteins, can act as immunostimulants, causing inflammation systemically in the body. Arthritis is commonly associated with Crohn's and colitis. There are certain autoimmune liver diseases that are certainly associated with ulcerative colitis and Crohn's disease as well. Primary sclerosing cholangitis is one of the major liver complications that can occur with IBD. Iritis is another problem, inflammation of the iris and of the eye. So we can see these systemic manifestations as well. Now, how can we help prevent that? Well, we can stop the inflammation in the gut as best we can, but we also have to impact the leakiness of the GI tract. The way to do that, particularly with Crohn's disease, is L-glutamine, which is an amino acid. Some very good scientific data and literature showing its ability to help restore the mucosa of the small intestine and heal the small intestine and enhance the development of those villi in the small intestine that are destroyed even in Crohn's disease. And then butyric acid or butyrate is a short-chain fatty acid, very helpful in ulcerative colitis and helping the colonic mucosa to heal and repair. And you can take it orally. In some cases with proctitis and lower end colitis, I will have patients use enemas of butyrate, and some pharmacies, compounding pharmacies, will put those enemas together for me and for other doctors. Other compounds that are very, very important, and probably most important with ulcerative colitis, is probiotics. We want to stick with the human-sourced probiotics. Probiotics are the beneficial bacteria in the GI tract. Now, the GI tract has more bacteria than a person has cells in their body. And the wrong bacteria, or an overgrowth of some of the wrong or gram-negative or endotoxin-producing bacteria, can be very, very harmful for patients with IBD. So we really want to get good beneficial bacteria in there. Now, bacteria should only be primarily in the colon, not the small intestine. So the bacterial treatments or probiotic treatments work best with ulcerative colitis. We certainly see that in the clinical data and the clinical research studies that have been done. Very high doses, getting up to 40 billion units of probiotic, of good bacteria per day, can actually have marked effect, beneficial effect, in the treatment of ulcerative colitis and proctitis, even pouchitis. That's patients who have had their colon removed because they weren't responding medically to the treatments for colitis, and they had their colon removed and a small pouch made out of the colon for the rectum. And they can still get some inflammation in that, and it's called pouchitis. And so there's some very good clinical studies showing high doses, over 40 billion units a day, can be very effective in reducing the symptoms and improving ulcerative colitis. But not so in Crohn's disease. I really want to make that clear. We do not see a positive effect in Crohn's disease. So, for Crohn's disease, I prefer to use something called Florastor, which is a Saccharomyces boulardii. It's a yeast extract that does not grow in the intestinal tract, but it stimulates reactions within the intestinal tract that are very, very helpful in Crohn's patients. There are about 2 studies that I've looked at so far, 2 or 3 clinical studies now, that have been done with the Saccharomyces boulardii in Crohn's patients, and showing that it reduced the occurrence rates of flare-ups and the duration of the flare-up and the intensity of the flare-up in patients who are using the Saccharomyces or Florastor. So that's a quick overview of IBD and some of the more natural treatments that I put in combination with any other medical treatment the patient may need to have to be in optimal health and optimal wellness with IBD. If there's anything more that I assure that these patients are on a multivitamin, which I assure all patients to be on, a multivitamin and mineral supplement. I assure that all IBD patients be taking fish oils. Fish oils are essential to Crohn's disease, but essential to IBD. There have been some very good clinical trials showing that the addition of fish oils at the level of 2,000 to 3,000 milligrams of EPA a day, EPA is one of the components of the fish oil, can be highly effective in reducing the inflammation and reducing the risks of colon cancer in patients with IBD. So fish oils are very, very important. And then lastly, I like to look at the vitamin D levels in these patients because they do have an inflammatory disorder. In many cases, they can't absorb B12 very well, especially with vitamin D very well, especially with Crohn's patients. So I will want to look at their vitamin D levels and make sure that we're maintaining their vitamin D levels between 50 and 60, 50 to 75 nanograms per milliliter per day. Sometimes that takes some good hefty dosing of vitamin D3, not D2 or any other form, but D3. And then lastly, vitamin B12 in those Crohn's patients who do have some evidence of B12 deficiency or have problems or have had problems of absorbing B12, we might put them on injectable B12 or sublingual B12 to get their B12 levels up. So that's kind of a quick quickie overview of how I work with IBD in my office. I know many people, colleagues, and patients have asked that I put this video together for them to give them a good overview of what I do in my office in treating Crohn's and colitis and microscopic colitis. So I hope you find this valuable. If you have any questions, feel free to contact us through TheDispensaryOnline.com. Thank you.